Hello, good morning, and welcome everybody to the European Kidney Forum 2021. My name is Tamsin Rose, and I have the great pleasure to be your moderator this morning. The theme for our forum is Unmet Needs and Challenges in Access to Treatments in Europe, the Case of Chronic Kidney Disease. Just a few housekeeping points before we begin. This event is being recorded and it will be shared with you afterwards. The hashtag for today, and you can see it behind me on the screen, is EKF 2021, and we look forward to reading your messages on social media. You can engage with us by submitting your questions using the Q&A or chat function that you'll find at the bottom of your screen. So today we have a packed agenda and lots of different excellent speakers who will give us some insight. But I'm delighted to introduce our first speaker of the day, and that's the Commissioner for Health at European level, Mrs. Stella Kyriakides. You're very welcome to join us. The floor is yours, Commissioner.
Thank you, Tamsin. Good morning, ladies and gentlemen. Let me begin by thanking the European Kidney Health Alliance and the MEP Group for Kidney Health for bringing us together today and for all the very important work on chronic kidney disease. To President Van Holder, his colleagues, and the members of this important alliance, I just want to say that your work to promote effective prevention and to ensure the provision of appropriate and affordable treatment makes a concrete difference to millions of patients across the EU. COVID-19 has taught us many lessons, but perhaps most powerfully of all, it has reminded us that we are stronger together. So as we begin the decade of the kidney, let us make this our guiding principle. Today, 1 in 10 Europeans suffer from chronic kidney disease, but more worryingly, the prevalence of typical risk factors like diabetes and hypertension are increasing. So I'm afraid that this means that the number of patients is set to grow. We need decisive action at all levels to reverse this trend. I want to start by saying that the new EU for Health program is a paradigm shift when it comes to approach to health. It's a testament to the historic level of ambition that this Commission has placed on health matters. And this program will give us the foundation we need to build a strong and robust European health union. It's going to allow us to increase the exchange of best practices between EU countries and to support networks for knowledge sharing and mutual learning. We are already supporting member states to reduce premature morbidity and mortality from non-communicable diseases as part of our commitment to the United Nations Sustainable Goals. But we have put forward as a Commission best practices related to health promotion, such as improving physical activity and nutrition. Through funding from the third health program, member states are working together on joint actions and projects that will help Europeans lead healthier lives. And I want to just say here that Europe's Beating Cancer Plan is another opportunity to address common risk factors for cancer and other non-communicable diseases. So we are going to be taking ambitious steps in the area of health, and also importantly when it comes to research. Under Horizon 2020, the Commission has funded already 40 projects with 64 million euro for chronic kidney disease and 24 projects with 47 million for kidney transplantation. And with the new Horizon Europe work program of 2021-2022, there are now more possibilities for research on chronic kidney disease, including dialysis and home care. Health policy is fundamentally about people. All politics are fundamentally and should be about people, about everyday life, about improving the quality of life of each and every citizen. This is why I want to stress the importance of integrated care for patients. We need to place the patient every time at the center. And we also need to emphasize the importance of disease prevention and promotion and health promotion. This concept fits chronic kidney disease very well because patients may need several types of health services, from their lifestyle advice to monitoring, dialysis, and acute care. And some chronic kidney disease patients will benefit from a kidney transplant. However, kidney transplants are not always possible for everyone, and this makes dialysis a life-saving procedure for many patients. Yet the organization of a safe, a comfortable, and a well-functioning dialysis system is a challenge for many health systems. And unfortunately, safe access to dialysis has been severely disrupted by the COVID-19 pandemic, at times either exposing the patients to a new risk or disrupting continuity of care. And I want to just also share with you how we are seeing the impact of COVID-19 on the access to care of many non-communicable diseases. It has also impacted, as we know, on organ donation and on the transplantation sector. Throughout the last year, we have continued to support member states to mitigate the effects of the pandemic on patients' access to transplantation and on the reduced availability of organs. But I know that we need to do more. And under the EU for Health program, we will further support professional associations to develop and share good practices and recommended actions. Ladies and gentlemen, the pandemic has now been part of, I would say, taken over our lives in many ways for the last 17 months. But it has amplified the need for us to build more resilient, more accessible, and more patient-centered health systems. And the EU for Health program and the ambitious European Health Union aim to build exactly that. This was the package that we put forward because we do see a European Union centered for health and for the citizen. We will continue to support the necessary research and pooling of knowledge to increase the quality of life and the life expectancy of chronic disease patients. But the insight and the expertise of all of you, all of the stakeholders in this forum are crucial. So let me just end, and I'm sorry if I have taken up more of the time, by finishing by thanking you again for your contribution. For us, it's so important because it's through your knowledge and experience that we can then move forward. And we are moving forward, and health is a priority on the agenda. And I think it will remain to be a priority on everybody's agenda for many, many years to come. I remember when we last had the opportunity of speaking, and I said then that we need more Europe in the area of public health. And I believe that is the case. That is the case when we're working towards prevention and we're working towards quality of life issues. So together we can improve chronic kidney disease prevention, we can improve treatment, we can improve care and quality of life. And I look very much forward to working alongside you in the coming weeks and months and hopefully years to achieve that goal. Thank you so much, and I wish you really very successful and fruitful discussions today. Thank you.
Thank you very much, Commissioner, for your kind words and also for highlighting how much health has now become a central element of the European agenda and is likely to stay that way. And again, reminding us the impact of COVID on the non-communicable disease treatment and access to care area. It's truly a big backlog of care that now needs to be reorganized and delivered. And we'll discuss that today, particularly the impact on chronic kidney disease. Thank you very much. We're now going to pass to our colleagues in the European Parliament, where we have a very active group of parliamentarians who are involved. And I'd like to introduce to you MEP Hilde Woutmans, who is the chair of the MEP Group for Kidney Health, and MEP Manuel Pizarro, the vice chair of the group. Let me start by passing the floor to Mrs. Woutmans.
Well, thank you very much, and welcome to this seminar. I think I first want to thank, of course, the Commissioner for our outstanding speech, and also Professor Van Holder, because he's the man who always works very hard on this. But I want to thank all participants and all speakers, of course. Chronic kidney disease is a major public health issue in Europe, with 1 in 10 Europeans suffering from the disease. And this burden is expected to dramatically increase in the next decades. Estimates show that chronic kidney disease will become the world's 5th cause of death by 2040. This growing burden has dramatic consequences on both public health expenditures and the quality of life of Europeans. If we want to slow and prevent the growing burden of chronic kidney disease while improving quality of life, all kidney replacement therapies options must become available to all patients. Cost-effective therapies exist, such as home dialysis, transplantation, or secondary prevention, but choosing the most appropriate therapy is not possible for all patients in Europe, which leads to significant disparities in availability and accessibility across countries and specific social groups. In addition, in the last 50 years, every aspect of life seems to have undergone substantial technological advances, but there has been little innovation in kidney disease therapies, regardless the increase of chronic kidney disease burden. The MEP Group for Kidney Health, of which I'm the chair, is working tirelessly with the European Kidney Health Alliance to propose solutions for the challenges of chronic kidney disease and facilitate the provision of affordable and appropriate treatment to all patients. Earlier this year, we supported the launch of the Decade of the Kidney campaign, which aims to put the spotlight on kidney disease at the European level for the next 10 years, and the World Kidney Day campaign, which aims to raise awareness globally of the importance of our kidneys. And these inspiring initiatives emanating from society and years to come need to be coupled with concrete EU action in order to make a tangible impact on the life of patients and citizens. The time to act is now. The heavy burden of chronic kidney disease has been neglected for far too long, and I call on the European Commission to give chronic kidney disease the attention and focus it deserves. At EU level, one obvious way to do this would be to put forward an EU action kidney disease. Since the begins at global level, the European Union could play a role in improving kidney health and access to treatment in low and middle income countries, which are disproportionately affected by the chronic kidney disease burden via the African, Caribbean, and Pacific Partnership and the African EU Partnership. Earlier this year, we launched, together with 90 European organizations, a call to action on improving prevention, treatment, and care in the aftermath of COVID-19, which the MEP Group for Kidney Health endorsed. This insightful piece provides sustainable and cost-effective recommendations to address long-term challenges surrounding chronic kidney disease in Europe. I strongly believe that most of these recommendations will be better tackled in a coordinated and standalone EU action plan on kidney disease. I count on the support of my colleagues in the European Parliament and the MEP Group on Kidney Health, the European Commission and the Council to work towards achieving this goal in order to provide optimal healthcare to all patients and tackle the chronic kidney disease burden. Thank you very much and good luck today.
Thank you very much, Mrs. Woutmans, and apologies to the audience, we had some slight sound issues there. Let me now pass the floor to your colleague in the European Parliament, Mr. Pizarro.
Thank you very much, Tanthim. I want to, first of all, congratulate European Kidney Health Alliance for this important initiative and give a warm thanks to the Commissioner Stella Kyriakidis for his kind participation, and also to make a special reference, mention to my colleague MEP Hilde Woltmans for his enthusiastic leadership of our group in the European Parliament. As you well know, chronic kidney disease was already a major public health challenge before the pandemic, but COVID-19 has exacerbated this burden. Patients suffering from chronic kidney disease are at a higher risk than those with other known risk factors. Indeed, mortality rates are worryingly high between patients with kidney disease. Furthermore, acute kidney injury has been reported in more than half of hospitalized COVID-19 patients. As you know, many patients with acute kidney injury with later developed chronic kidney diseases. So COVID-19 is likely to increase this overall burden of the disease in Europe. I'm fully aware of this burden as my own country, Portugal, has one of the highest rates of end-stage kidney disease. This may unfortunately be due to a lack of preventive measures and poor control of risk factors of chronic kidney disease. Yet, the COVID-19 pandemic should be a wake-up call on the benefits of prevention over cure. Not only is it favorable to patients, but it also reduces costs and would prevent the healthcare system's overburden in the aftermath of the pandemic. Integrated approaches and target investments at both EU and national levels to eliminate key lifestyle-related risk factors should now become a first on political agenda. As Vice Chair of the MEP Group for Kidney Health, I am committed to support the European Kidney Health Alliance in its efforts to reduce the burden of chronic kidney disease and to improve access and availability of kidney replacement therapy. In particular, I would like to highlight the need for EU coordinated action in the field of organ donation and transplantation. Kidney transplantation is the gold standard for treatment of chronic kidney disease. The delivery of this treatment option in Europe has greatly improved during the implementation of the first EU action plan on organ donation and transplantation. Building on this success is essential. I have submitted a parliamentary question last month asking whether the European Commission was planning to put forward a second EU action plan. This would help member states to harmonize different approaches among countries, facilitate coordination and progress monitoring, and improve access to transplantation as the best treatment option. We now have a fantastic opportunity to improve the lives of kidney disease patients with the momentum in the European Health Union and ambitious programs such as Horizon Europe. I have already seen a positive step forward with this program as it recently published a call on medical technology and devices that made a specific reference to radically portable dialysis. I hope future calls will follow suit as groundbreaking innovation in this field is urgently needed, especially in preventing progression of kidney disease. Well, the clock is ticking, but I am confident that with strong political leadership, adequate research, funding, and cooperation between all sectors, we will be able to make a positive change for chronic disease patients. I am very much looking forward to supporting the kidney health community. Thank you very much.
Thank you very much, Mr. Pizarro, and clearly a lot of support from the European Parliament for the programme going forward. We mentioned earlier, and you heard that from the Commissioner and others, the idea of a decade for the kidney. So we're going to now hear a little bit more about that, and I'm delighted to introduce two people who'll give us some insight into that. We have Professor Ray van Holder, who's the President of the European Kidney Health Alliance, and Henning Sondergaard from the Danish Kidney Patient Association. So we're going to hear from two perspectives, and we're first going to understand some of the challenges around access to kidney care and treatment, and then secondly, we're going to see what we can achieve in that decade for the kidney. Professor van Holder, the floor is yours.
Thank you. Thank you very much. I would like to have my slides on the screen, please. Yeah, my presentation is on unmet needs and challenges in kidney care. And to set the stage, 1 in 7 Europeans is currently suffering from chronic kidney disease. And on top of that, dialysis kills faster than cancer. CKD, or chronic kidney disease, costs more than cancer. And it ruins quality of life, as you will learn from the next presentation. So taking this into account, the question is whether all valid candidate patients receive the treatment that is appropriate for them and which is their preference. And unfortunately, the answer is no. On this graph, you see the frequency of transplantation per European country, and the length of the bar is corresponding to the number of transplants per million people, million inhabitants. So you see that there are huge differences among European countries, which means that in a number of countries, or even many countries, there is much place for improvement. And on top of that, the different colors are showing different types of transplantation: living donation, deceased donation, expanded donation. So again, there are very much differences. So here also there is room for improvement. And in the insert, you see a picture of the uptake of peritoneal dialysis and home dialysis across European countries, and it is the same. And it is fair to remember that transplantation has the best quality of life, the best survival, and costs least to societies. And for peritoneal and home dialysis, it is also the best quality of life and the lower cost. So there are really reasons to promote these types of treatment. But there is more than that. There is also a number of inequalities in the access to treatment and also in the availability of treatment. And for the time being, therapeutic options to refrain the progress of chronic kidney disease, there are only very few solutions, so we need more than that. But on the slide, you see the back of a patient with itching and scratches. And itching is an issue that is often forgotten by the nephrologists, just simply because they do not ask for it. But many people are suffering from it, and there are few treatments. And if there are treatments, they are not given. And on the right side, you see a number of other patient-centered outcomes, much of them related to the neural system and to mental health. And quite often we do not know the cause, and as a consequence, we do not have specific CKD or chronic kidney disease related therapies. But there are also inequalities among social groups, and there are problems especially with people with low income, with low education, low health education, problems with certain ethnicities, with migrants, with refugees, and we should not forget that there is also still a gender issue in nephrology. And that brings us to another essential topic, that is education and information of the patient. In this inquiry by EKHA, we asked for patients on kidney replacement therapy on their satisfaction with information on peritoneal dialysis. This for several European countries again, and the red bar is illustrating the dissatisfaction. So on average, there are about 35% of European people who are dissatisfied with the information they got about PD. And believe me, it was worse for home hemodialysis, and it was barely better for transplantation and barely better for living donor transplantation. So here again, there is a lot of work to do, and especially there seems to be a lack of training of professionals in offering proper information to patients, and also benchmarking that is assessing whether there is satisfaction with the information and whether the information has been complete. So we need to improve this all over Europe. And then there is also the issue of reimbursement. An interesting evolution took place in the United States, which you can see in the blue line on the graph. So from 2011 on, reimbursement of all treatment systems for dialysis was kept the same. So that means in-center hemodialysis, which is the largest part of dialysis, but certainly not the preferred one, low quality of life, lower survival, and high cost. But also the same reimbursement for home hemodialysis and peritoneal dialysis. And look what happens. The downward trend that was there till just before the change of reimbursement is modified in an upward trend that is not present for Europe, as illustrated by the red line. So is then equal reimbursement the sole solution? We do not think so, and even we think it's not the optimal solution. If we look then at the figures for Europe that were shown already before, illustrating the huge discrepancies among European countries. If you look at the red box, you see the Scandinavian countries, and they have an uptake of peritoneal and home dialysis of more than 30%. And if you ask over there what they are doing, they do not reimburse equally, they reimburse the real cost. That means that no benefit can be made on kidney replacement therapy. And also, again, there is a lot of focus on education, general population, patients as well as professionals, and on timely referral. Patients who come in late to the nephrologist are usually channeled to the non-preferable in-center hemodialysis. And again, there is also a lot of emphasis on benchmarking. So these are our wishes: access for all, access to all options, with the help of telemedicine, which is a novel evolution, but I think it will make things, and especially education, much better possible. A need for equality, for education, for shared decision-making, and for fair reimbursement. But above all, what we need is awareness of the general population and of the policy makers, because there is still a lack of this awareness. And that is the reason why with EKHA we decided to join this Decade of the Kidney, which is a splendid initiative from the American Patient Federation, which is running from 2020 to 2030, where we want to create an increase in awareness on kidney disease so that we come to a similar situation as has been done with cancer over the last 30 years, with a really splendid effort that has been done by the European Union. I thank you for your attention.
Thank you very much. And you've set out for us some of the challenging goals that need to be achieved by the end of the decade, and also quite alarming data on the lack of good quality information that's being provided and the extent to which that affects patients across all of the different treatment options. Even the gold standard treatment option, patients don't feel that they're getting the information that's of high quality. So now let's have a little bit of more insight from a patient perspective, and I'm delighted to pass the floor to Henning.
Thank you very much. Can I have my slides up, please?
And Henning, I apologize. I should have introduced you from the Danish Kidney Patient Association, just so everyone knows where you're from. And your slides will come up.
Right. All right, here we go. So the big question is, who am I? Why can I not see my slides now? That is a problem. Oh, well, I'm not able to see my own slides. I can only see my picture. That's a bit of a problem. Well, who am I? That's a question that we have all pondered. I was born with spina bifida, a condition of the spine that renders me paralyzed from the waist down. If I was born 20 years later, I would have ended up here as an abortion, basically, because my disease is not desirable. But I ended up here in a wheelchair, and I have made the best of my life living in a wheelchair. As a young man, I was a disability activist. Then I became a sportsman. I played basketball, I raced, I skied, and I traveled the world. Then I became a psychologist, and for the past 10 years, I have been a dialysis user. This is supposed to be the international symbol for disability, a person in a wheelchair. Since I can't see it, I just hope that my slides are following my speech here. But for me, the wheelchair is a symbol of my freedom. The chair has been an opportunity in my life. I have never really felt disabled until I started dialysis. So I think the symbol for disability should be a dialysis machine. Am I one ahead now? Thank you. The symbol for disability should have been a dialysis machine. It has kept me immobilized for 30 to 35 hours a week for the past 10 years. And I can't do anything seriously while I'm on the machine. All I can do is watch mindless entertainment or sleep when I'm lucky. But it's my life, and I can't escape dialysis except in a casket. So how do we improve dialysis so it becomes easier to do? A better question might be, why are so many people treated in the hospital when they would feel so much better at home? This is one of the big questions today, and I will not go into more than one or two aspects of it. So let me say this. In-center hemodialysis is the worst treatment option when it comes to quality of life and longevity. In other words, you live a short life full of disease. Even then, this treatment is given to more than 95% of the world's dialysis population, probably because it can be given to everyone. But it's like with everything else. One size does not fit all. And it is time for us to stop saying, have this or have nothing. The next worst treatment, um, the next worst treatment option is peritoneal dialysis, but it only works well as long as there is some residual kidney function, and we know that the body can't handle it for more than a few years until it breaks down. By far, the best dialysis is home hemodialysis. So those of us who do dialysis while sleeping at night are the healthiest, and we feel the best overall. This is no secret, and let me show you a study that clearly shows this.
No, I
Here
think
are
you are one ahead again.
Yeah.
I'm
I
one
think
ahead again.
Yeah.
This is the graph with the bars.
Now I can.
Yeah.
Oh, now I can see them. Oh, now I can't see them again. Okay, well, I will try to do it as well as possible. These are two figures from a study done with nephrologists and nurses about 10 years ago, where they were asked what type of dialysis they would prefer. 93 or 96% of the nephrologists say they wanted a home option, depending on whether they would be transplanted or not in the future, while 89% of nurses would prefer a home option, regardless of their transplant situation. I have always wondered why so many professionals prefer this treatment when they give virtually all their patients an inferior one. I have no logical answers to that question, but it's truly mind-boggling to me. So let's look at other aspects of dialysis instead that are important if we want to improve the lives and longevity of patients. So how do we improve dialysis treatment? Time is of the essence here. We simply cannot speed up the process. Just like in traffic, speed kills. Trying to remove fluid from the body too fast is dangerous, and eventually the heart will stop pumping because of this. But this is just one side of the problem. Another side is, in order to remove toxins, the blood needs to be in contact with the filter as long as possible. Again, time is of the essence. This begs the question, why do I need to be stuck in one place while I do my treatment? Not only is it unhealthy, it's also extremely unproductive. This is why we need to invest in smaller dialysis machines that are truly portable, yes, even wearable, so we don't have to waste so many resources by patients being tied up in one place while they're doing their treatments. And, and this is where we have had the biggest problem so far. While virtually everything has gotten smaller in the past 50 to 60 years, dialysis machine has stayed the same size or sometimes even gotten bigger. There simply has been no incentive to invent smaller machines. Manufacturers and healthcare professionals have seen no point in it, and patients apparently have never really been asked. But a comparison to this development, uh, in computer electronics is illustrative. This is what 5 megabytes looked like in the early 1960s when the dialysis machines were introduced widely in the world. And this is what 2 terabyte looks like now. It fits between our fingers. And remember, 2 terabytes is 400,000 times as much storage as 5 megabytes. 400,000 times. That's quite a lot. So to illustrate this, I have here a picture of the National Convention Center in Shanghai. It is 400,000 square meters compared to an English phone booth.
One further. Yeah.
One
That's it.
further. Here we
now
go.
yeah.
Yes. Every time I'm interrupted, I can actually see my slides. That's sort of funny. So anyway, to illustrate this, this is a convention center that is 400,000 square meters compared to an English phone booth, which is 1 square meter. And for years, I have said, if the development in consumer electronics had followed that in dialysis machines, my mobile phone would have been the size of 4 city blocks. And it turns out it may even be bigger now that I think of it. But it's not just consumer electronics that have gotten smaller. It happens all the time in the medical field. Most things have developed and gotten smaller, except for dialysis machine that sometimes have gotten bigger instead. And this is a great example, I think. It's an iron lung. Like the dialysis machine, It was a massive technological advance in the 1950s and 60s, but what happened to all those people who were confined to one of those in the old days? Well, it's not like they're dead. They're just out there living their lives. Here is one of them. On the left is my friend Anders, who is hiding behind a young girl with Anders, and with and he's on the left, and I am hiding on the right behind the young girl we took for a trip on Anders' sailboat last year. Anders cannot move his body at all due to a fracture in his neck. He's wearing a ventilator which allows him to breathe. You can see the ventilator here. It's the band around his neck that gives a signal to his lungs so he can breathe. That and a small control box the size of a toiletries bag on the back of his wheelchair is all he needs to be able to stay alive. So when Anders, who is completely paralyzed, crosses the Atlantic Ocean this summer, I'm stuck in one place tied to my machine 5 times a week. Thank you for listening to me.
Thank you very much, Henning. I think your presentation was very powerful, and you brought it home to many of us who are not involved in the day-to-day business of dealing with kidney patients, to understand just what a huge impact this has on the day-to-day life of patients and how little innovation has been brought into this sphere. So I think it was very helpful to get that perspective. We'd now like to invite the audience to share some input with us. We're about to have a panel discussion which is going to look at how we tackle the current challenges in access to kidney disease treatments. But what we want to do is understand from you, and we're going to launch a poll, so be ready to answer on this. We want to know what you would like to see achieved at the end of the Decade of the Kidney campaign in 2030. And we're going to give you 5 options, and we'd like you to choose one, please. The first option is, and the poll's just being launched as I speak, the first option is that health professionals and patients are fully educated and informed about different treatment options for chronic kidney disease. Now, Professor Van Holder explained actually that levels of information are very poor at the moment, so that would already be a major change. Second option, increased political and financial incentives for cost-effective chronic kidney disease patients. And again, we heard that it's ineffective and expensive, the in-center dialysis, and yet that's what's offered to the majority of patients. So we're clearly a long way from getting cost-effective chronic kidney disease treatments. The third option, perhaps you think the priority should be optimum availability of all chronic kidney disease treatment options in all European countries, because they're not equally available at the moment. A fourth option you could choose as what you'd like to see achieved would be home therapy defined as the first-line dialysis option. And again, we've just heard how 95% of patients don't get that. So that would be a big shift in the proposals. And the fifth option you could choose would be increased use of telemedicine by both patients and health professionals. So we're inviting you to choose what we would like to see achieved at the end of the decade. And the voting should be open now, so I look forward to seeing your views. And I'll leave the votes open for a few seconds. And while I do that, I'm just going to introduce who are the members of our panel before I start asking them questions. We have Daniel Gallego, who's the president of the European Kidney Patients Federation. We have Jan de Messner, who's a professor in family medicine and primary care. We have Jeanette Finderup, who is a clinical nurse specialist and from the Transplant Nurses Association and the European Renal Care Association. We have Professor Ray Van Holder, who spoke earlier, and who is the president of EKHA, the European Kidney Health Alliance. We have Lieven Annemans, a senior health economist at Ghent University, and Stefan Schreck, who's an advisor on stakeholder relations for DG Santé inside the European Commission. So that's going to be our panel. And I have some specific questions for each member of the panel, but I will also have a chance to bring in questions from you, the audience. So please feel free to use the chat function or the Q&A function at the bottom of the screen to send your messages. Let's close the poll now, and I'd like to see the results. You were given 5 options to choose, and we asked you, what would you like to see achieved at the end of the 10 years? Now, clearly there's a lot to do, but I can see that the number 1 is home therapy defined as the first-line dialysis option. That's got 31% of the votes. That was followed by health professionals and patients, fully educated and informed about the different treatment options. That got 21%. 14% of you went for increased political and financial incentives for cost-efficient treatments. And then we also had genuine availability of all treatment options in all European countries. That got some support. And finally, just 4% went for the increased use of telemedicine. But the number one thing that people have clearly come up with, and I'm fairly sure you influenced this vote with your very powerful message about the realities for patients of trying to go through this. So the clear winner that came out was that home therapy is defined as the first-line dialysis option. Okay, so let me now turn to the panel. I'm going to start with Daniel. In-center dialysis is the most commonly used kidney disease treatment in Europe. And we have evidence that transplants and home dialysis offer better health outcomes for patients. So from your perspective as a patient, what are the remaining barriers to fully unlock access to these better therapies? Daniel.
Yeah, good morning, everyone, and many thanks for the opportunity to share with you the kidney patient's voice and the kidney patient's perspective in this important field. Of course, I'm a kidney patient undergoing hemodialysis since 1995. We are fighting more or less the same barriers to the access and to promote the home therapies and the better kidney replacement therapies. Of course, I think the first one is cultural barrier, because healthcare system is disqualifying the patients before choosing, and usually they think that they only for young patients, and usually is believed that the training for home therapies or for transplant is too challenging and difficult. And trust me, it's more difficult to learn to drive than to do the home dialysis or to get or manage the kidney transplant. And this paternalism and this tradition and customs is not benefiting the kidney patient. Of course, there are some physical barriers, because nowadays home therapies, you bring the disease at home and you need a lot of place and space for the supplies and the room and storage. So we need an innovation to achieve that the home therapies becomes wearable and portable, and these facilities and at home, and not dedicate a room or your home to all the supplies and all to manage the home therapy. And of course, we will love to increase the access to the kidney transplant, because it's the best kidney replacement therapy, and we see a lot of inequities in the access across Europe, and we need to improve that with data, with the best practice, with protocols, and there is, of course, financial and barriers and healthcare system barriers to everything is planned and organized for the dialysis at centers and the hospital, and we get used too much to go to the hospital, and this is the main reason the home therapies are underused and underestimated, and
okay.
and this is more or less the where we need to enable the real shared decision making and develop tools to help choosing and to promote the chronicity should be managed at home whenever it's possible.
Thanks, Daniel. I mean, I think you've highlighted again the cultural and attitudinal barriers that are the first ones, because until people think that it's possible and that patients are capable of doing it, nothing else will follow. But we also need to take into account the technical and practical realities of what this actually means. Thinking now about primary care, which is where patients are dealt with in the community, let me invite Jan to pick up on this question. The key here is preventing the onset of chronic kidney disease or even its progression, and this should be the key focus around kidney care. As a general practitioner, do you think that access to primary and secondary prevention could be delivered in the primary care environment? You're on mute.
Yeah. You're still
Just
muted.
unmute.
Yes.
That's it. Great.
Thank you very much for the opportunity to speak here and for the invitation by the European Kidney Health Alliance. Of course, in primary care, we have, can I have the slides, please? Can I have the slides?
Yes, we have the slides up now.
Okay, that's great. What we have seen in the COVID-19 is that primary care really is very important in dealing with the problems that we are facing. And we learned a lot about how hospitals and primary care should be complementary in addressing challenges. And both in the report by the expert panel on effective ways of investing in health and in a recent document by the OECD, it was emphasized how important it is to strengthen primary care. And when I have the next slide, I hope you can see it because I can see it. In chronic kidney disease, of course, primary healthcare has a very important role to play. First of all, in early detection of the problem, because that's a very simple thing, and the family physicians can do it at a primary care level every day. It's looking at patients. It's simple blood testing and analysis of urine, but certainly the most important thing is to really discover those patients that are at risk. And of course, patients with diabetes, with hypertension and obesity are three groups of patients that we meet every day and that we should look after in order to see if they are not developing problems that can be indications for chronic kidney disease. So our role as GPs is first of all that we have an accountability for the patients on our list. And I think it's so important that in health systems, all patients are enlisted with family practice so that they can be followed up. And there, the special task we have is to address social inequities, as was mentioned already by Professor Van Holder. We have to reach those most in need because they do not access hospitals. They are in the community, and we can outreach to them and try to find out and follow them up when they are at risk. Of course, population screening, I think, is not of value, but what we do is case finding in high-risk subpopulations, and those three groups of patients with chronic conditions are very important targets to address our actions in order to early detect the problems. And of course, as already mentioned, we can contribute as family doctors to increase the awareness and knowledge. Information is very important. More and more, we will do that in interprofessional teams. The isolated family physician is something from the previous century. Today, we work together with nurses, with pharmacists, with other healthcare providers, dietitians, and so on to address the challenges. And recently, with the expert panel on effective ways of investing in health that I chair, we wrote a document on task shifting, how we could better share competencies in the primary care level. The last thing we do as GPs is we can, of course, support the home care. We had the privilege in our practice to take care of one of the first patients in the previous century with the Department of Nephrology of Professor Van Holder that was treated with continuous ambulatory peritoneal dialysis. But I think today that Henning's call was very clear. We should make technological process in order to have new and acceptable forms of home hemodialysis. The next slide wants to go on into the issue of access. We documented the issue of access in Europe, and we saw that equitable access to health services is dependent on appropriate financial resources linked to health needs, and this certainly applies to kidney disease. Services should be affordable to everyone. There should be relevant, appropriate, and cost-effective services. Everyone should be able to use the services when they are in need, and services should also be acceptable to everyone, and that requires information. We need well-equipped facilities within easy reach. We need the staff with the right skills in the right place. And last but not least, we need quality medicines and devices available at fair prices. And in a recent study by WHO, it was put attention on the fact that more and more of our therapies are impoverishing because the health spending brings people from above the poverty line to below the poverty line and their families, and that's really a problem. Moreover, we see more and more catastrophic health spending where households can no longer afford to meet other basic needs like food, housing, and heating due to the spending for healthcare. And when we look what's the most important factor in a breakdown of out-of-pocket payments by health service, among the households with catastrophic health spending, we see that medicines account for the largest factor that impacts catastrophic health spending. And I think that accessibility of medicines is a very important issue that we should look after carefully in order to give access for our patients to equitable treatments. Thank you.
Thank you very much, Jan, for putting that into perspective again and giving us the overall view of what some of the patients' challenges. Let me now turn to Professor Ray van Holder to say, are there gaps that we could address in the way we currently educate and inform nephrologists about different treatment options? And remember the earlier studies that showed that people were unhappy with the level of information. The patients were unhappy with the information they were currently receiving, and that when the professionals themselves were asked, they would want a completely different set of treatment than is they're actually delivering to their current patients. So how do we change that?
Yep. First of all, what I would like to say, I don't like the word nephrologist. I think it's much better and broader than that. So it's even not only doctors, it's also professionals, certainly nurses, but even other people working with kidney patients. That's one thing. The second thing is that it needs to be done on all levels. So it's starting at the student level, but also beyond that in specialisms, which goes beyond nephrology. There are many other specialties that are giving kidney failure and that are not entirely aware of what is happening. And it is also for formed professionals, for ones with a graduation, so in postgraduate teaching. So it's all over the place. And I want to stress especially also the role of nurses in this area. That's more or less all. No, if you want more, then I think the teaching goes beyond just awareness, but also teaching in how to approach the patient and how to give complete information in an objective way and helping the patients in making the appropriate choice, which is theirs, not ours.
Thank you for that. And you mentioned nurses, and that brings us to the next person I'd like to bring in, and that's Jeanette Finderup, because you're a nephrology nurse, so you're in the day-to-day contact with patients. Do you think there are gaps that could be addressed in the way that we currently inform and educate our patients about the different treatment options?
Thank you for the option to represent the nurses in this panel discussion. And thank you for the question. And the short answer to that question is yes, but to elaborate this yes, I will tell about a project in Denmark implementing an intervention called shared decision-making and dialysis choice. The intervention consists of a patient decision aid and meetings with a dialysis coordinator. The meetings being supported by different parts of the patient decision aid. The intervention is delivered by special trained nurses. They are trained to deliver the intervention based on tailoring and using different communication skills and the method shared decision-making. And research about that project has shown that this intervention involved the patients in the decision-making process about dialysis choice. And it was the meetings with the dialysis coordinators and the patient decision aid they were the two active mechanisms which contributed most to the decision-making process. And we also found when involving the patient in the decision-making process, the choice of the dialysis modality changed. In this project, 72% chose a home-based treatment. And this is an example from Denmark, but it's not usual practice all over Europe, although we have had international recommendation regarding involving the patient in the choice of dialysis modality for decades. So a lot of patients throughout Europe do not experience to be involved in the decision-making process. And not all countries do have patient decision aids to use in the decision-making process. Some industrial information leaflets are available, but they are not patient decision aids. They are commercials, convincing the patient to choose a specific type of treatment, the treatment the company is offering. In Denmark, the patient, if not having any contraindication, are able to choose freely between dialysis modality, both peritoneal dialysis, home hemodialysis, and center hemodialysis. And to my knowledge, and from the speakers earlier today, the option of peritoneal dialysis and home hemodialysis are not option for patients to choose between in all countries in Europe. And it's not just about having a choice and making a choice, but it's also about implementing the choice. If the patient chooses a home-based modality, then we should offer the patient optimal training, but also patients in center hemodialysis are in need of training. So we have gaps in relation to involving the patient in the decision-making process, but also involving the patient in their health and also involving the patient in their care and treatment.
Thank you very much, Jeanette. Now, it's very interesting to hear how when patients were given choice and they were given information and taken through a decision-making aid, the vast majority, almost 3/4, said they wanted dialysis in the home. That was what was going to suit them best. Let me now pass to our next speaker, and that's going to be Lieven Annemans, who's a health economist. And we heard earlier that the cost plays a role. You certainly need to have equipment at home, but it's certainly expensive to do dialysis in health centres, so it can't be the only decision maker. Can you tell us, from your perspective as a health economist, what are the economic factors that would influence a choice between different dialysis modalities and transplantations? This is an understanding that health systems are always looking for good value, good return on investment. So what are the economic factors we need to think about?
Yes, thank you, Tasmin. Let me first emphasize that health economics is about health and economics. It's not only about economics. And the challenge of healthcare system is to optimize the health of the population within the limits of the available resources. So cheaper is not always better. Sometimes we see that there is a treatment option that is more expensive than another one, but relatively offers a lot of what we call quality adjusted life years. And if that ratio between the cost of that investment and the health benefits for the patients is an acceptable ratio, then we have to go for it. We have to invest in that treatment option. Let's never forget, the goal is to invest in health. Healthcare is not a cost issue, it's an investment, and that's something we should never forget. Having said this, there is a factor that is quite important, and that is the perspective of the analysis. Sometimes we see treatments where, for instance, the hospital perspective encourages that particular treatment. For instance, in many countries, hospitals gain more when they apply hospital-based hemodialysis. And we know, and we have already heard it today, that often the home-based option is better, but if the financial incentives are not encouraging the right choice, then we have a problem. And Ray gave a nice example of Scandinavia, where the reimbursement is in line with the real cost, so that there is no monetary benefit to be obtained by either choice. And that's something that should be applied everywhere. Third, and Jan de Mazener already mentioned it, it's the patient contribution. If for a given option, patients have to pay more, then this will discourage patients to go for that option. So there again, we have to make sure that the patient contribution does not influence therapeutic choice. And then finally, what is also important to understand, that is when we compare different treatment options, we have to make sure that we look, we take a long enough time horizon. So a treatment should not be based on the short term and the short-term impact, both on the finance and on the health. We should really take a long-term horizon when we go for a given treatment option. So these are the 4 points I wanted to make.
Thank you very much. They're very clear, and I think you've highlighted again for us how financial incentives in a system shape the environment within which decisions about clinical care get made by both patients and their caregivers. So clearly this is an area we need to look at. And you highlighted that some countries have managed to make it sort of the choice more neutral in terms of economics, to take that issue out, and that resulted in different decisions. Let me now turn to the European Commission, to Stefan Schreck. Now, of course, member states have the full responsibility for health systems. It's not directed from Brussels, but there is a role for Brussels and the European Union in helping to share some of this best practice. And we heard from the Commissioner at the beginning the political ambition and the new financial instruments. There's the EU for Health, the Next Generation EU Recovery Funds. So there are these options. What can we do to roll them out to make sure we can address some of these imbalances? And when we've got good practice, how to make sure that becomes the gold standard for everyone else to achieve?
Yes, thank you very much. and thank you for inviting us to this meeting. And indeed, I will start with maybe reading you the first objective of EU for Health, our new program. That says, improving and fostering health in the Union to reduce the burden of communicable and non-communicable diseases by supporting health promotion and disease prevention, by reducing health inequalities, by fostering healthy lifestyles, and by promoting access to healthcare. So clearly, addressing these imbalances is indeed part of the EU for Health program. And more specifically, it says the program should address inequalities in access to healthcare throughout the Union in a manner that creates efficiency gains and value-added impacts that could not be generated by action taken at national level, while respecting member states' competence and responsibility in the areas covered by the program. So, which basically means what we cannot do with EU for Health is replacing healthcare costs which a member state doesn't want to pay. But what we can do is, as you say, we can help exchanging best practice, we can help exchanging expertise, and we can do things together with several member states, which are easier to be done together than to be done alone. But the motivation to do it clearly needs to come from member states. And of course, there are also other funding options. And while, for example, the EU for Health program is a program which supports multilateral collaboration, so the money does not go to individual member states, but to a group of member states doing things jointly. But there are also other financial instruments like Next Generation EU or the European Social Fund Plus or the European Regional Development Fund, which support individual member states. In those cases, however, the planning is carried out by member states. A key element of the Next Generation EU is the Recovery and Resilience Facility, for example, that has a total budget of 672.5 billion euros. The focus actually is on promoting economic, social, and territorial cohesion, strengthening economic and social resilience, and also mitigating the socio-economic impact of the crisis. So I'd say clearly addressing healthcare imbalances in the area of kidney care would be covered by this. It is, however, member states which prepare and submit their recovery and resilient plans, which are the basis for the allocation of the budget. So health projects to improve kidney care can be funded, but only if, on the one hand, they contribute to the overall objectives, which should not be so difficult, but they also have to be included in the National Recovery and Resilience Plan. So the short summary is it is possible actually to finance addressing those imbalances from the available financial instruments, but it has to be included in the national planning, which is forwarded to the Commission then and approved by the Commission. Thank you very much.
Thank you, Stefan. I think you've given us a challenge for us to deal with, which is to make sure that at member states, they're both aware of the possibilities of using EU funds to do this, and then build this into their program. So there's clearly some work to be done. I'm going to come back to the speakers for another round, and we're starting to get some content in from the audience as well. Danielle, I've got a question for you, and I think it links quite nicely to a question we've had from the audience, because we've asked, is there a role for fellow patients in patient education through peer education? So I think that's something I'd like you to think about as I ask you about the last 15 months, the pandemic really impacted on chronic disease patients. They were the most at risk of severe outcomes if they made it into hospital with COVID-19. And partly also because their care was disruptive. If 95% of patients with chronic kidney disease were being given inpatient dialysis, and that was largely disrupted, there's a huge impact on their lives. So what would be the lessons that you would learn? So maybe you could pick up on the role of patients as peer educators, and then, because that may be linked to some of the lessons that were learned.
Yes, absolutely. I would like to have a loving memory for all these families that hundreds of thousands of patients have died during the pandemic because they cannot isolate themselves during the lockdowns. So you can imagine we were in panic to go to the hospitals or dialysis units. So the first lesson is that the kidney replacement therapies such as kidney transplant and home therapies are the safest during the pandemic. So this is the first lesson, that we used to go unreasonable to the hospital and dialysis units at center. So we need to change the paradigm and to think about it. Of course, another lesson is to collect everything has worked to the kidney patients with the best practice, the best protocols, clear protocols to prevent and manage the communicable diseases, and to promote this kind of kidney replacement therapies basis at home. And uptake, another lesson is to uptake the telemedicine, the phone consultations, all the digital tools, the telematic assistance, the virtual support that works perfectly, and to combine presence and the face-to-face meetings with the digital tools, and be careful to don't leave anybody behind, because not everyone is able to access to the telemedicine and digital tools, and not everybody has a smartphone or a laptop. So we need to be careful of that. But of course, we need to develop these digital tools, and these automatic and renovation prescriptions. All has worked for the kidney patients. I think is truly important to consider. And
Okay.
of course, yeah, I think this is the most important lesson that we have learned during the pandemic.
Thanks, Daniel. And specifically on this issue of digital health, maybe we could bring in Jeanette, because you've talked about this this digital app that was a decision-making aid. Do you think that there is a role for digital health in helping to bridge some of these gaps, get better information, help people be aware of the different treatment options so that there can be different pathways? Jeanette?
Yeah, thank you for that question. And I think we are so far with digital health, so the only answer to that question is yes, but I'll also have some consideration regarding the use of digital health. First, I want to give you some information regarding the mobile app. Henning Søndergaard from the Danish Kidney Association, who earlier spoke about innovation, were the one who had the initiative for this app. So the wish of having an app came from the patient, and patients were involved in the whole project about developing and evaluating this app. And the patient decision aid I mentioned earlier, it was integrated into this mobile app. And now for some of my consideration, the average age of a patient in Denmark who have to make a choice about dialysis modality is about 67 years old. So it's not a young patient population. And using a mobile app, you have to consider if the patient population have the skills to use an app, although one of the participants in our study was 86 years old. And it's not just about skills, it's also about having access to a mobile phone. A very large percent of the total population in Denmark has access to a mobile phone. The recent data is about 96%, but I'm not sure how this is all over Europe. Earlier, I talked about shared decision-making. Patient decision aids, if it's in either in paper format or in app format, it's able to provide knowledge about the decision to make and help the patient to consider what matters most to the patient. But a patient decision aid is not shared decision-making. That's what happened between, shared decision-making is what happened between the patient and the healthcare professional. And working with digital health is not to replace the encounter between the patient and the healthcare professional. As one patient put it, if I should have made a decision without the meetings with the dialysis coordinator, it would have been hard. I would not be able to see which option is right for me. In the encounter, we use the patient decision aid in paper format, because then it is a tool we use together, the patient and the healthcare professional. But digital health is excellent for the patient to work with before and after the encounters. And digital health has a role, and we have to use it. There's a lot of talk regarding personalized medicine, and the future innovation regarding digital health is personal digital health, where the app is tailored to the patient's specific data and situation and needs. That's my wish for the future of digital health.
Thank you very much, Jeanette. We're now going to go to Lieven to talk about some economic issues, but we've had a question from the audience that I'd like to bring in at this point, because you spoke earlier about, looking at the value and the importance of, it's not just about, money, it's also about health outcomes. And we've had a question that said, how do we best measure value in the context of home therapies? Are we measuring the things that really matter to patients, like convenience, comfortableness, the ability to do things and live their own lives? You mentioned quality adjusted life years, and that's a standard thing that health economists might measure. But how do you build in some of the elements that came from Henning when he talked about quality of life and freedom and, to be able to go out and live their lives? Is that part of a QALY?
Yeah, excellent point. So indeed, our goal is to try to gain as much as possible quality-adjusted life years for the patients. And there are nice studies, for instance, a recent study comparing home dialysis with peritoneal dialysis, showing that home dialysis leads to more QALYs to the patients, which is fine, and which led them to the conclusion that it was cost-effective. But the QALY is focusing on functioning, on daily care, on anxiety, on pain, but it's not always capturing everything that really matters for patients. So the patient-reported outcomes that are specific to your condition, the patient-reported experience, they should also be taken into account to have a full picture of the value of a given treatment option, indeed.
Thank you. Let's keep running through some of these questions that we're also getting in from the audience. Jan, let me turn to you. Chronic kidney disease rarely evolves on its own. You mentioned earlier that it's often patients with high blood pressure, with obesity, with diabetes and other issues. Given that context, obviously patients are going to need care from multiple professionals in different areas. And what we really need is to have proper integrated care. But healthcare systems are fragmented. Everything's organized according to specialities that own a specific disease. So how can we create patient-centered care with multimorbidity, particularly for patients with chronic kidney disease? You're on mute, Jan.
Yep. Still muted.
So, okay. Patients, this is a very important question. But let me first make a remark. I think in COVID-19, what was very important and what we did in our country, in Belgium, was that we first vaccinated people at risk, and people with chronic kidney disease were in the first range of those people at risk that were vaccinated before we went to people with no risk factors. And I don't know how many countries did, but in Belgium we managed to have a selection process involving sickness funds information, involving information by general practitioners, and also by some specialist doctors. And altogether, we could identify 1.5 million people that had increased risk for COVID-19, and that could be vaccinated. And dialysis patients were one of those, and chronic kidney disease patients were other one. And I wonder why not more countries took that strategy to really make a selection and a priority for people with chronic conditions. But that being said, very correctly, people with chronic kidney disease, most of the time, they have multiple problems. They have a kind of hypertension, diabetes, obesity, all kinds of risk factors. And very often what we see that this care for those people is very much fragmented. And that's really a problem nowadays. We have our single disease kind of project, single disease kind of guidelines, and that leads to fragmentation. And following on what Lieven Anneman said, can I have the next slide, please? I would like to emphasize the need to change our paradigm when we look at the way we approach the patients nowadays. Do you see the next slide?
Yeah, we see the James Mackenzie lecture slide.
Okay, very fine. Because in that lecture, we emphasize the need for a paradigm shift from disease-oriented care towards goal-oriented care. And I think that is very important. We have to start from the life goals of the individual. what really matters to the person. And that should be the starting point. And that should be much more integrated in our care, certainly in patients with multimorbidity. And once it is clear what the life goals are, and very often those life goals have to do with social participation, have to do with mobility, have to do with social interactions, we can see which strategies we can offer to really try to achieve those life goals so that patients can live the life they want to live. And also in our medical record, when you look at the right down corner, right side under, I think that our medical records should start from the life goals of the patients, so that any person, a nurse, a doctor, a specialist, a GP, that sees this patient and meets with his patients can start from the life goals. And an app can help people to formulate their life goals on a continuous basis. And if the first screen that pops up when we see a patient would be the life goals of that patient in that moment, I think we would have a completely different orientation of our care processes. And I think that's very important. On the structural level, I think that we should much more evolve from this disease-oriented approach to an integrated approach. And nowadays we see that there is a lot of investment in vertical disease-oriented programs. And of course, that's helpful on the one hand, but I think, and we started a campaign 30 by 2030 in order to make a sensibilization that the disease-oriented categorical budgets that very often are sponsored by specific donors, that they should invest at least 30% by 2030 to strengthen the horizontal primary healthcare systems so that all diseases can be prevented and people treated in a comprehensive way. And so we would like to urge countries to encourage that vertical programs, including disease-specific programs, are developed, integrated, and implemented in the context of integrated primary healthcare, and hence also avoiding inequity by disease. You can go to our website, www.30by2030.net, and you see already many people signed this petition. I think we should really try to have a comprehensive approach, starting from the life goals of the patients and have an integrated approach to addressing the different disease in multimorbidity patients. And that, I think, was a message that I wanted to add to this debate. And the last point is we absolutely should make a priority that African people can be vaccinated for COVID-19 because it is a disaster, actually. And also that is something that is our collective responsibility. Thank you.
Thank you for that and reminding us of our global solidarity issues. I'd now like to bring in Professor Ray van Holder to answer a question that we've received from the audience, which is how can we double the effectiveness of kidney research in a few years? We talked about what should be the goals at the beginning. We asked you what we should be aiming for by 2030, and we've heard there's some gaps. So what would be in your bucket list to double the effectiveness of kidney research? Where are the gaps where we could really make progress?
Yes, first of all, I would like to start to ask that the European Union or the European Commission puts kidney disease in its priority list of healthcare problems to be dealt with. You can find the whole list on their website, but there is not chronic kidney disease. There are a lot of causes of chronic kidney disease, but chronic kidney disease is not there. And then we need more awareness of the problem, and then this needs to be supported by financial support and research support. Our feeling is that the topics that come out, for instance, in EU for health, no, not EU for health, sorry, for Horizon Europe, that they are not always directly kidney oriented. I may be wrong, but I think the other point is also that we would appreciate more possibilities to look at and compare different diseases and see which investment is done for specific diseases. Mr. Schreck mentioned in his previous intervention a number of initiatives and also Mrs. Kyriakides, which for support was done for chronic kidney disease. So it would be very good that we can find these and compare these to other diseases, because we know from UK and United States that still kidney disease is under supported as compared to other chronic diseases.
Thank you. Let me now turn to Stefan from the European Commission, because we've clearly come to the point where we're asking what the Commission can do. Let me refer back to the action plan, the first EU action plan on organ donation and transplantation that ran from 2009 to 2015. And that had a huge benefit. It increased the numbers of transplants, etc. If the gold standard of treatment for chronic kidney conditions is in fact transplantation, what are the chances that we could get a second European action plan in order to roll that up? Because the first one had a measurable impact. Stefan.
Yes, indeed. The Action Plan 2009 to 2015 provided actually some valuable outputs to strengthen transplant systems, there we agree, in particular by developing, documenting and disseminating good practices between member states' transplant authorities. Those outcomes are still relevant and a lot still needs to be done by our member states to implement the organizational improvements in their national transplant systems. So actually the results have not yet been fully implemented. And we do not immediately plan a new organs action plan, but we have continued to support the sector through funded actions also after 2015. An important project has developed patient registries to help assess best organization of kidney transplants and to protect living donors. A related study has quantified the cost benefit of kidney transplants compared to alternative therapies for patients with end-stage renal failure. Another one has organized awareness building events across the EU. And the Commission also hosts a network that brings transplant authorities and professionals together to discuss common concerns. This network has proven very useful during the COVID crisis, which has indeed significantly impacted transplant rates that we know. But the network has been sharing good practice to strengthen resilience of transplant systems in case of crisis. And finally, the Commission is planning to strengthen EU-level resilience of transplant practices within a COVID-like crisis context with support under the EU for Health program. So this is what we have in mind for the near future.
Thank you for that, Stefan. And I note that we're sort of running out of time here, although we've tried to bring in the questions from the audience throughout. Before I pass the floor to Professor Van Holder for closing remarks, I'd like to bring in Lieven one more time, because we're starting to get questions about money and financial incentives and how they impact the choices of treatment. So, I mean, do we need to adjust the financial incentives to support improved treatments? And if we offer more treatments, will it actually reduce the financial pressure that health systems are under? How do we make the money an effective part of the decision making? Lieven.
Yeah, indeed, not easy, of course, but let's remember the goal. The goal is to optimize the health of the population. And if we take one step back, there is clear evidence that the best investment to do is to avoid that people get diabetes, to avoid that people get hypertension. That is the most cost-effective thing to do. And once people have, for instance, diabetes, once people are at risk for chronic kidney disease, then it's also a question of being as early as possible in the intervention. Also, that has been shown that being early there is also more cost effective. But then, even with the best possible prevention, there will still be people with chronic kidney disease evolving to end-stage renal disease. And I think there, it's crucial to have this multidisciplinary approach. This, for instance, a multidisciplinary consultation involving also the GP. Also there, it has been shown that this is cost effective, because that can really allow to select the optimal treatment for every patient, and that is crucial. And maybe I want to also stress that the ultimate goal is not necessary to reduce the financial pressure. Of course, the financial pressure is there, but the ultimate goal is to optimize the way that we spend our healthcare money. And we will only get there when every patient really receives the best possible treatment for that patient, and that should then also be the most cost-effective treatment. Final point maybe, when we think about incentives, when we think about economics, we should not be cost myopic. We also always have to have an open view healthcare is kind of a communicating vessels. If we invest in a given treatment, for instance, recently I was involved in remote patient monitoring, patients on peritoneal dialysis. The remote patient monitoring reduces the chances for peritonitis, and that leads them to less hospitalizations, less ICU, less antibiotics. So we always have to have that open view to look at all the consequences of a given treatment, and only then we can better select the best possible treatments for the patients.
Thank you very much, Lieven. And it's been a really exciting forum this morning. I think you'd agree. We started our conversation an hour and a half ago asking questions, what could we achieve over the next 10 years if we put the money and the focus and the attention in chronic kidney disease, which is not getting the attention that it deserves, and it affects large numbers of Europeans, and we expect the number of people affected by it to grow as a result of COVID. So let me now turn to Professor Van Holder to close off the forum and give us some final words.
Yeah, thank you very much. We are extremely happy with this event, and I think it taught us a lot, especially I think about leaving silos, because that is one of the problems we are facing still as of today. So I only can thank everybody for their excellent contributions. First of all, the organizations that supported us financially. I think I was said or told that they would be displayed at my back, but they are not. But in any way, they are also there in all our correspondence. Then I have to thank the board of directors of EKHA for supporting this initiative, and especially Martijn Ubbink from the Dutch Kidney Foundation, who was sitting on the work group that was preparing this meeting intensively. Then I have to thank also all the people who worked with us to make this possible. First of all, at Intrel, the team around Marine 4, Sarah Soruri, Alicia Bay, who were very supportive in doing all this and elaborating this, and then also the team around Evelien Scheres in the Netherlands, Els van Maurik, Laura Vernooy and Senja Kome, I think. Then I have to thank all speakers for their excellent contribution, the audience with a number of questions. Part of them may still have to be answered during the afternoon, then we still can think further about this. And then finally, of course, also Tamsin for her excellent moderation. And now I give back the word to her to close this meeting right in time.
Okay. Thank you for that, Professor Van Holder. Yes, as you said, it's been a really interesting morning. I think we've talked about perspectives of clinicians, nurses, we've looked at the patient perspective, we've looked at the ranges of treatments that's available, and it's very clear to me that there is an enormous gap between what would be an ideal situation and what's currently happening. Part of it can change in the way that information is provided, and that's to do with training the healthcare professionals and giving patients access to it. Part of it is rolling out digital supports that would make things more streamlined and more efficient. But partly it's also reconfiguring our health systems to address this better and to recognize that, kidney disease patients may have a limited prognosis, and we've heard that they have, chronic kidney disease. If you're in in-center dialysis, it will kill you faster than cancer. That's a very sobering thought. But we also heard from Henning the possibilities of life if we see things differently and if there is a support out there. And I think my one takeaway from this is I would go away and call all innovators out there, people who do health hackathons and others, to say we have to liberate kidney disease patients from the wall and from those enormous machines. There is a huge potential out there, and it really needs to be met. And we can see here on the screen the different organizations who financially supported this meeting and made it happen. We thank you very much. As you've heard, there is an enormous need. The kidney patients across Europe, and it's a significant number of people, 1 in 10, need better innovation, they need better support, they need a wider range of treatments so that they can contribute and live their lives. We thank you all for joining us. I hope you will join us again for 2022, when there will be another European Kidney Forum. The PowerPoints from this and the recordings will be made available on the European Kidney Health Alliance website. Thank you and goodbye from the studio in Brussels.